All right, thank you for staying with Daybreak. Before I get into your feedback, you're talking about the state of healthcare. We'd like to hear your views and opinion on it. Has it worked? Has it not worked? But let's talk about devolution. Now it's closer to you. And Dr. Davji, I'll start with you. Was that a good idea, or should we just take this thing back to the national government? Has devolution worked?
I think this I will handle in two ways.
Yeah.
We look at devolution in terms of the infrastructures in the counties, pre-devolutions and currently. And I will say that in terms of constructing hospitals and constructing facilities over the years after devolution, that has actually improved in many of the counties and in different parts of the country. But then offering services will become a different objective and different direction, because once the facilities and the infrastructures have been done, which governors and different leaders in the counties are good at doing, because that gives them optics directly to the wananchi to show that they're doing the work. But are those particular facilities able to offer services, quality services to the Kenyans? That's a question that we have to ask. Because you realize that in many cases, all these facilities, I've seen an hospital, a level for hospitals, which has 15 beds. For pediatric, 20 for adults, almost, I think, 60 beds. But the all hospitals don't have any doctor. And those are, a sub-county will have 3 or 4 of such types. So the structures are existing, but there are no equipment in those facilities. Yeah. There are no drugs in those facilities. There are no human resource in those particular facilities to run them. And in most instances, the county will say that they've reached a selling point that they cannot employ any more workers. So essentially, there is need to have Health Service Commission that will manage the human resource centrally, and we leave the structures for the counties. Because then with that, the counties will be able to demand the number of workers they need for the service provision in those facilities that are constructed. Yeah. You realize that in the last 3 months, there are many counties in this country that have not paid salary for the doctors and for the healthcare workers that are in the counties. To the point that I will tell you that the healthcare workers in the counties happens to be the highest who are in the CRB list currently, because their salaries are not coming consistently as much as that they needed to be in the hospital consistently. Yeah. That's a great failure, or a great failure in the devolution. In the division of human resource of healthcare. Yeah. We've also seen situations whereby there is the governors who are the different counties treating healthcare workers differently. For example, we've seen for the first time healthcare workers being dismissed irregularly by county governments, like in Laikipia County. We had 34 specialists dismissed. The wananchi have not been getting services in that county for over 2 years. They've been on the street agitating, but then they cannot get the services. We have seen the same in Kirinyaga. We've seen a governor recalling specialists in Kitui, of which when he's asked for the reasons, he will say that his job is to offer services, not to train the specialists needed for those particular services. So in a nutshell, we can say that the devolution in terms of structures has worked, but in terms of human resource is really failing. Yeah. Yes.
Dr. Ngani, what do you think?
Well, Trevor, the matter of devolution of healthcare is very close to my heart, because when it was being done, I was the chair of the union, and I think we had many conversations all to very high levels. Yeah. And at that time, we were advocating what is called practical devolution. There was, unfortunately, a lot of discussions around pro-devolution and anti-devolution. Healthcare devolution, our stand had always been that there is room for devolving healthcare. Allowed the counties and the local governments to make decisions around where they're putting facilities, how they're going to run those facilities, day-to-day running, ensuring that those facilities work and are responsive to the people, and ensure that the services are very close to the people. But one thing that we foresaw a problem with was human resource management from back then. And we've been consistent, and we've said, please allow human resource management in healthcare to be handled centrally, not centrally being national government, but through a Health Services Commission. This is something we've spoken of for about now 8 years, consistently, and actually, believe it or not, it was in Bomas, the Bomas draft. There was room for Health Services Commission. The founders of devolution said, devolve healthcare and have a Health Services Commission, because then the kind of thing you are seeing now, Trevor, we're in a country that is far short of doctors, yet there are more than 2,000 unemployed doctors in the country today. it's the craziest thing. I can't, you know, I've been on this for so long, I'm almost giving up, wondering how is it that it's Dr. Were here who's saying this, or Davji who's discussing, you know, employment of doctors. Every single person out there should be concerned about this. And if you're running for anything, even if it's an MC or even a sub-MCA, you shouldn't be running for anything if there are unemployed doctors in your country or your county and you're not talking about it. There are countries out there that people would resign because they're unemployed doctors within a certain period of time. And in Kenya, it's become almost the norm. So if we had a body whose task was to deploy and rationalize human resources, health devolution would work much, much better. The biggest challenge the counties have faced is paying salaries. They can't employ more because they don't have a bigger budget. And all these battles would have been long dealt with had we been a bit more keen. And again, it comes back to the same thing. We'll come here and talk, and it's like someone decides that we don't know what we're talking about. We are just troublemakers. I've had those kinds of labels, yet if we try what we've tried for the longest time, it hasn't worked. Why don't we try something different? Why don't we listen for a short while and see how much better healthcare is going to be? And I'm convinced that will make a tremendous difference. And I'm going to ask the Mwananchi who's listening, I want you to make healthcare your business, your agenda. Because right now, the healthcare agenda is not working because of all the middlemen in the supply chain. You know, Kenyatta had a plant for making IV fluids, the maji ambayo inaongezwa kwa mishipa. Kenyatta had it. It's not working because someone has to supply IV fluids. This is where we have to pay attention to and deal with those issues. But it won't start if, as Mwananchi, tumekubali kudanganywa kwamba wafanyikazi wa afya ndio shida. I'll also say this, and to the healthcare worker out there, if you're meant to be in a public facility and you're not there and you're fired, that's okay. In fact, I recommend that anybody who is drawing a salary and not working in the facility, you have no business being there, because the value of our work as doctors is a service you give, not because we are doctors, because of what you're doing. So if you're not present, the guard at that hospital is of greater value than you are, and therefore that expense is not merited. But I'm saying this is not the bigger problem you're facing. A bigger problem is that it's a system that is not working. It's a system that has to be fixed. Fixing it requires radical measures. Some of those measures have to be implemented. It will not happen when the supplier in the county comes to tell you that the reason the things are not working is because yet they've eaten all the money. They have their friends who made the supplies. They didn't supply a single thing. They didn't supply a single drug. They bring a whole truckload of paracetamol into the county. No drugs for basic services. That will not solve the problem. No.
Something you mentioned there that I don't want us to skip on. You said that there were IV fluids that are supposed to be made by Kenyatta, but
Kenyatta had a plant.
Somebody wanted to supply it. It didn't happen?
Kenyatta is such a big facility that it's able to produce a lot of the things that it uses and have enough market for what it's producing. And I think one of the wiser people in the past, because Kenya, as you know, our history, there was a time that Kenyatta was the best facility in the country. You know, it's over time that it became dilapidated to some degree. And it has capacity to generate IV fluids by itself. But you see now, if you're to revive it, you're going to kill business for somebody. You know, and this is the reality of life. And the same thing cuts across. Trevor, when we speak about middlemen in healthcare, middlemen in service provision, this is a really big problem that has to be paid attention to. Of course, it's dangerous to say those things because you're touching on people's bread and butter. But look at the tenders, look at the suppliers. You know, when you talk about ownership of facilities in the public sector, there are owners of facilities, and those owners are not government, and they are not Mwananchi. There are people who are involved in this supply process, and this is track the money that goes into those facilities. And if you deal with the corruption in that chain, Trevor, there's no reason why the public facilities shouldn't be better. And by the way, Mark, pay attention. There are some facilities that are coming up now. I think NMS is trying to put in place some measures. Let's watch how those facilities go so that we can say this concept actually works. And there are also, I think a few counties have been mentioned. There are facilities where they've actually put in place measures and those facilities have worked. I've given the example of MTRH. You see what MTRH is doing in terms of dialysis, in terms of kidney transplantation, and you know it's very possible. And by the way, no private investor, no private hospital owner can out-invest government. There's no reason why only one private hospital, for example, has a particular scanner in the whole country. Why couldn't we have done that? You know, people are going to India and South Africa for the longest time for something that we can bring and make available. And someone shouldn't have to travel from Lokichar all the way to Nairobi for something of that nature. They also have require the same services. And it's not impossible, Trevor. It's just that we have to stop believing that I'm the problem. I'm not the problem. I'm trying to provide a solution. And you'll not listen to me if you believe that I'm contributing to the problem. The problem is that we don't listen to the people who actually have the solutions to make a difference.
Okay. Dr. Were, on this issue of devolution?
I think devolution has worked by bringing the infrastructure closer to the people and access to basic service. But in terms of quality delivery of health and affordable health for the Mwananchi, I'm sure if you ask anyone around, people are still having the same challenges that they had 10 years ago accessing quality service from our facilities. Because of the lack of human resource for health, there are no healthcare workers there to provide that service. In some instances, we're even seeing counties saying it's cheaper to provide poor medicine to the public by hiring healthcare workers who are not within their training to provide that service. So you'll see they don't want to hire doctors because they're saying doctors are very expensive to maintain, which is just a fallacy, because if you compare what the job group that most of our doctors are vis-a-vis the management bloating in most of these counties, then that is the biggest fallacy that is being propagated by politicians. So the only thing that devolution has made it, as far as you're concerned, it has brought the infrastructure. But in terms of operationalization of that infrastructure, it's still lacking. Look at the COVID situation, where we had 300 isolation units all over the country. But Trevor, the last 1 month, people have been running from one private facility to another to try to get that ICU bed, to get treatment. Why? And 47 counties put 300 isolation facilities. So it tells you there's a serious problem of governance in the health sector, all the way from the Ministry of Health to the devolved units in the counties. And that, if it's not fixed, then we'll be here 10 years later discussing this same issue. And we need to separate business from provision of health service. Health is an essential service and should be seen like a social need that each and every citizen of this country need to have access to. Once we remove that issue of capitalism, extreme capitalism in the health sector, they will have access and devolution might work.
Okay. Dr. Ngani, now that Dr. Were has brought it up, the issue of ICU, and I know this is now your area of expertise, what is your assessment right now and what needs to be done to make it better? Because like Dr. Were is saying, it is true, we saw 300 beds capacities in all 47 counties, but now we're being told that the ICU is full.
Trevor, there is the political creation of ICU and there's a functional creation of ICU. So which one do you want me to talk about? Because politically, we have created many ICUs. You know, someone will go and say, okay, now we have made this ICU. There's a very nice label there. There's a contractor who has been paid a few million shillings to put that sign there calling it an ICU. But in fact, in terms of capacity, when COVID really hits, then this person has to look for an ICU somewhere. And that's a tragedy. And Trevor, the theme of my discussion this morning is to make care for healthcare not just the healthcare worker. I'm not talking about doctors only, the nurses. It shouldn't be an issue, a problem for the healthcare workers only. It's a problem for every single Mwananchi and every single politician. Because the question the Mwananchi should ask is, this ICU that has been created, show me, why is it not working? You said it was there, why is it not responsive? We can do this. We just have to be very deliberate about it. Unfortunately, that we haven't been able to do it because creating an ICU is not as simple as having a bed, even a ventilator. No, you have to create human capacity to make that work. It means that the 1 year that COVID has, we've got a grace period by the grace of the Almighty God to create capacity, train, because training takes time. About a year or so to train many of these doctors who are jobless on the street. Could have brought them into the critical care setting, given them some training. Some of the nurses who are now being pushed by countries like Britain could have been brought into critical care training. We could have put in place equipment and protocols. We could have done that because many private hospitals have done exactly that. But government, we haven't been able to do it. We've actually utilized the resources to create, other services that don't meet that capacity. Let's say if we didn't plant a tree yesterday, this is the time to plant. So even now, we have that capacity to start today. And we don't have to start with 300 ICUs. We just identify every single facility and increase that capacity. The Critical Care Society of Kenya is present, and it's a society that will be able to give guidance to make this happen. But we have to deliberate about creating fractional ICUs. It's a process that can be done. Do you know of any place where there's ICU facilities? Because I've spoken to some of my friends and relatives who are telling me that we went to this county and we were told ICU is full. Do you know anywhere where there's space right now? Well, okay, right now... what is our capacity as a country? There's an assessment that returned 580 ICU beds, and this was all-inclusive, that considered all the ICUs that were working and all the ICU beds that were just ICU beds by label. And I'll tell you that is far short. That's the number of ICU beds we should have in Nairobi alone. I know that a lot of private hospitals have increased their capacity. That data has not been updated, and I do know that a number of private hospitals within Nairobi today have ICU capacity. I'll tell you that my ICU, we have a bit more space now, which is different from 3 weeks ago when you couldn't find a single bit of space. The COVID wave has gone down. And Trevor, you are right on the money here, because what we've seen about COVID-19 is that it comes in waves, and another wave is coming. Mind you, you can just tell by what we are doing as a country over the last couple of weeks, and within a short time we'll be in another crisis. So within this time, before the wave really hits, we have the chance to go out and actually assess functionality and increase that capacity. It means that as of today, every single county government should be in a place where it's identified the people who are undergoing critical care training, both doctors and nurses working in units that are functional and creating, putting together the equipment that is needed. And I must give a warning here, because the same thing that we've suffered from, of fraud, it also exists within the equipment space. So people are selling really low-level equipment at extreme costs, and the things that cannot be used functionally within the facilities. So again, there's area of regulation in that particular area. My recommendation, let us actually partner with the Critical Care Society of Kenya to put up ICUs that are functional. I think from that group, the society is able to give guidance. I think KMA as well is able to give some guidance in this. If we give leadership for such a process, I don't even think people will be able to volunteer and assist the countries build critical care capacity.
Okay. Dr. Davji, you know, you mentioned earlier on that we have more than 1,500 doctors who keep coming from school, and about 2,000 who are unemployed. But we still saw the Cuban doctors coming in. Did we need those Cuban doctors?
I think Cuban doctors is another scam boiling in the Ministry of Health. You know, we are in a country that corruption is always planned. It does not happen the time that we see it. So one of the time bomb that I'm sure one time will blow in the Ministry of Health is the issue of the Cuban doctors. There's need to actually give audits for the ones who came previously, and even the ones that are being brought. Because ideally, you realize every Cuban doctor is getting paid almost 1 to 1.5 million per month from the taxpayers' money. That is from their salaries, from the funds going back to Cuba, and even from the logistics and from the way they stay. So there are a lot of kickbacks and a lot of things that are involving the Cuban doctors. But if you look ideally as a country, we need doctors. And we have many doctors who are doing family medicines and all other specializations that need to be employed as a country at much lower cost that the government has totally ignored. We have doctors who need to go for postgraduate studies that the county governments actually refusing to release to go for those specializations. And to some who have gone to school have been recalled by some county governments. We have a situation whereby also the education itself has been put to cap out Kenyans from being specializing. We saw in the recent fee increment, the University of Nairobi has increased fee threefold, which means that if you are paying fee initially at 2 million or at 1.5 million to get masters, now you're paying 7 million. This will cut out many of the Kenyan doctors to get this specialization. So it's a way to still create business, to import the Cubans, to import the Ethiopians, to import the Indians, to import all this, because that is a business I think the Ministry of Health is currently doing. It's the same thing that I was saying. We saw the KEMSA scandal recently. We saw the scandal in NHIF. So in NHIF, so the ministry has been there's scandals that are being brewed every time, and these same thing escalate down into the counties. So I believe the Cuban issue is just a scam that very soon will be exposed and will see a different face in the ministry.
Yeah. Doctor, what do you think? I mean, we were told they were specialist doctors and we needed their support to come and increase the capacity of our own local doctors.
I think, Trevor, this country has the best trained doctors in our region. And if you look at Kenyan doctors, they are much sought after. And they are running most of the health systems in sub-Saharan Africa. If you look at Botswana, look at Namibia, Lesotho. Those health systems are being led by Kenyans. Even in DRC Congo, look at the US market, UK market. Kenyan doctors are well-trained and they're able to deliver services that this country needs. We have more than 1,500, 2,000 doctors who are not in any kind of formal employment. You saw the president the other day went to UK and negotiated for employment of nurses because you have a glut in terms of not being able to absorb nurses here. But then here we have a Ministry of Health, which now goes to Cuba to bring an additional 53 doctors who we don't need. Because if you critically look, and this is one thing that KMA is going to be asking as part of the right to access to information, we need an audit report of the previous cohort of Cuban doctors who came here, because the report that we have in terms of their performance. You'll hear stories like in Kitui, there was a maxillofacial surgeon. In Kisii, there was a plastic surgeon. But those are very isolated cases. But for the majority of cases which we are aware of, this group of doctors actually did damage to the public. It's just that the public doesn't know. And you see, that ball falls squarely in the council, the Kenya Medical Practitioner and Dentists Council. You cannot bring in doctors who are less qualified than the ones that we have here in this country, so that you can pick or flow with a certain political narrative. So I think we need to look at that issue critically.
Yeah.
Be patriotic. Yeah, we have to buy Kenya to build Kenya.
Yeah.
We have 1,500 of our youth who each and every day are running from institution to institution doing part-time jobs, who can be comfortably employed with a salary that is being now allocated to provide for these Cuban doctors. Remember, when the Cuban doctors come here, they're provided with security, they're provided with free housing and other goodies that Kenyan doctors don't have access to. So I think it's just an issue of patriotism, it's an issue of the governance in the health sector and accountability.
Okay.
I think the Cuban doctors who are here have done more damage to the healthcare system than the good. And for the record, we do not need Cuban doctors to teach us how to actually take care of our own patients. We've been doing that since independence.
Yeah. Dr. Ngani, I know you've dealt with this issue before, and have you gotten some sort of light about it?
Well, my view is slightly different from my seniors, and respectfully, I actually believe that we need as many doctors as you can get into the country.
Yeah.
I actually believe that if you get me UK doctors, Cuban doctors, we are short of about 40,000 doctors. That's the reality. So get me the 40,000, I'll be happy. But my problem with the process that has been done is you're telling me you're getting 50 more doctors from Cuba and you haven't employed 1,500 in your country. You're not being, the genius who thought about this concept doesn't really understand what they're doing. This is unfortunately the case, because you have 1,500 unemployed doctors and you're looking at 53 that you want to, subspecialize, some subspecialty of some sort. We want a doctor who can do a cesarean section in a county. That doctor is on the street. For one Cuban doctor, you can employ 5 or 6 Kenyan doctors, and you're not doing that. That's the first problem. Second problem is this inferiority complex, this ukoloni mamboleo that has made us believe that you can pay a Cuban cardiologist, a foreign cardiologist, a Mzungu cardiologist 4 times a Kenyan cardiologist, and it's okay, you can live with that. Those kinds of small snippets of insecurity, those snippets of the past that really shouldn't be part of a society today that we've allowed to be, those are the issues we need to address. If you're saying that a cardiologist working in Mama Lucy should be paid this amount of money, it doesn't matter whether the cardiologist comes from UK or comes from Kochwadi Center down in Olokicha. There is a cardiologist providing a service. That is what it's supposed to pay. And before you say that you are looking for more doctors from outside, get as many doctors as you could into that space. And Trevor, you see, these are the problems. So it's the same genius with such a solution who's providing ingenious solutions to making UHC work. And I can tell you the same disaster that we've seen in the Cuban doctors process, where the government has spent ridiculous amounts of money for minimal output, is the same thing you're going to do with UHC, enrich a few suppliers in the middle, and UHC doesn't deliver anything. For those same people today, under UHC program, if they suffer critical COVID, need an ICU, they have to sell everything they have to access critical care. And we have to change that. I think it's been said over and over again, trying the same thing over and over again doesn't give you good results. Try something different, and I keep requesting that of us as a people.
Yeah, Dauji.
Yeah, I just want to put out the discrimination aspect that the Ministry of Health is putting in handling the Cubans in terms of getting the salaries on time, everything well planned and well organized. And then we have about 300 doctors that are employed on a 6-month renewable contract by the same ministry. But these doctors, after every 6 months, have to delay without salaries. Like, for example, the doctors currently working in COVID centers, they do not have any medical cover. They have not been paid their salaries from the month of June, and they do not know when their contracts will be renewed. But they're the ones in the front line, in the COVID isolation unit, in every part of the country, under the same ministry. So that gives a glaring aspect that if we are Kenyans, and we have Kenyans who are actually sacrificing and working in the COVID centers and are not getting their issues sorted, but we have the Cubans who are given a different aspect by the same ministry. That shows where our priority is. Yeah. Yes.
All right.
Trevor, allow me to just say this, because for the Kenyan doctor, you know, when we started the union, my salary was 50,000 take home. I think, and for us to make a small change in what the doctor is earning, it's a fight. Look, the Cuban doctor is coming and getting multiple times more than the union has ever asked for the senior most doctor, without a single fight. What is the reason? Can't we just then say, okay, fine, we think the value of a doctor is this much. You retain, stay in this public sector and work this way. Why does it have to be a strike for 100 days, costing lives, for a small change to be made that then seems to make sense for a foreign doctor?
Yeah. Some of them were saying that it's because of the impact of the debt to government. As in taking care of doctors, they say, was expensive at the time. The government was arguing that they can't sustain it. Even if they agree to the demands, it will not be long-term because there's not enough resources. You're not buying that argument?
Absolutely not, Trevor. The cost of paying the doctors, I think, was barely, was it 15 billion over 3 or 4 years? We have a 3 trillion budget as a country. Look at every country that has developed. No single country has developed in the world that hasn't paid attention to healthcare. No single country. And I think we have to get to that level where we say if it's good enough for the US citizen, it's good enough for the Kenyan citizen. But this notion that for the rich man in this country, the child who has a cough, a flu, common cold, must be seen by a super specialist, while for the Mwananchi's child who's suffering severe pneumonia, severe malnutrition, that person doesn't have access to a doctor. To think that is acceptable in this society, I think that's where we have been. But I'm saying, and I'm asking every single young person out there to think of it different. That this country has to change, and we must have the basics being guaranteed to anybody, regardless of your social status. If you're paying your taxes, you have a right to healthcare. That healthcare is provided. I'm telling you, it can be provided at a decent enough level if we focus and do the right thing.
All right. Let me bring in a bit of feedback before we take closing remarks from my guests here in studio talking about the state of healthcare. Let's bring them up and see what you're saying. And Trevor Mbija at Citizen TV Kenya, use the hashtag Daybreak. Agumba Steve says, how is the government going to take care of those unable to pay the NHIF? Can the government ensure that NHIF salvages where it should? A number of health centers would rather receive cash and dismiss the card. Could there be delays with the card cash? All right, let me hear your views on that. And Dr. I'll start with you, Dr. Were.
Yeah, I think as far as NHIF is concerned, I've mentioned that there need to be a provision.
Yeah.
We call it the indigent. These are people who are not able to pay. And I think as we move towards implementing UHC, then the government needs to allocate funding to NHIF to take care of that. The challenge that we have, and I think a good thing that is also coming from that bill, is the issue of access. Because you don't really need to go to a health center to see a doctor. You can actually go to the clinic for that doctor and still get the services that you need to. I think that is a positive thing that is coming out now that we're going to engage the service provider who will be the doctor or the healthcare worker directly vis-a-vis going to the hospital-based system as it was in the old Act. So when that is done, then it will ensure that everyone has access. And the thing that NHIF need to do is to ensure that they do also pay for the service in a timely manner. So they need to look at their governance structure. Yeah. They need to reduce the cost of administration. 40% of their money goes just to administration aspect. So they need to look at that bloated governance structure or management structure and see how effective they can be in terms of honoring the provider obligations.
All right. Let's bring up another feedback. Let's see what's going on there. Canol says health has so many issues. Why can't they post clinical officer interns? We heard that they have issues with PSC. They should solve their issues and get us posted. What is the state of interns, Dr. Davji?
You know, basically, once clinical officers, the doctors, and all the healthcare workers finish their studies, they ought to be posted for 1 extra year for training within the facilities as they work. So basically, this happens by the Ministry of Health, through the PSC generally, because that is a delegated authority by the PSC, the ministry. So this happens immediately after the institutions have reported the numbers that they've received. So still, these need to be posted. Whatever the clinical officer is concerned about is that they have done with their studies and they need to be posted to offer services in different institutions, and that has delayed. So probably I think the ministry need to look into it and sort it out.
All right. Yeah. Let's see what else is coming through, bring it up and see. Angela Lazaro says the persistent crisis in the health sector is created by 2 groups of stakeholders. One is fighting for reorganizations, while the other is busy fighting to enrich themselves from the loot. Okay. Jacob Abere says, in Kenya, health service delivery tool is very good, but what fails is financing and human resource management, insufficient drugs, exaggerated bills, and overwhelmed personnel. And that is why citizens who are able to go to private hospitals do exactly that, okay? Inyakweba says, devolution took healthcare farthest from Wananchi. I know of a county with several dysfunctional dispensaries and health centers where mothers walk miles to a county referral hospital to have a normal delivery, and yet there is a structure of a hospital at the neighborhood. Okay? Chikamau says, the rain started beating us when the government started fighting with the sector. If the health sector could be sufficiently catered for, I think we'll look for specialists. They can concentrate in service providing rather than getting into business. All right, so I'll start by taking closing remarks from you, Dr. Awere, and I'll start with you. So, for this to function properly in this country, what are the things that need to be put in place? You've mentioned financing, you've mentioned human resource. Is it a matter of just goodwill, or do we not know where we're heading? Is it policy issues? What needs to be put in place so that healthcare works for the people?
I think we need to have proper policies in place. And these policies will be in place if we sit down together, because as doctors, we actually want UHC to work. That will mean more work for us, and we love doing, we love treating patients. But the challenge that we are having now under the current regime is the isolation of the professional's voice. There is no way you'll allow, for example, an air hostess to fly that plane that you're in. But we're seeing a situation where in Kenya, where we are trying to isolate the key service provider, who's the doctor, in favor of political and business interests. And that needs to stop. We need to sit down at the table with the Ministry of Health, with the Council of Governors, have a health conference, and talk about how can we smoothly implement the health service provision so that we stop the suffering that Mwananchi is going through. And this is possible. The only thing that we need to do, listen to the voice of the professionals within the sector. You cannot balkanize them, you cannot isolate them, and then purport to be providing health service to Kenyans in this country.
Would it make more sense for the likes of KMA, KMPDU to have individual conversations with the governors of each county? What are their strengths? What are their weaknesses? How can it be fixed? Because they all have different capacities.
Yes. In fact, that's what I'm alluding to. My brother, Dr. Davji, are actually looking forward to having a health conference just to talk with the Council of Governors and address all these issues holistically and try to find a lasting solution. And we are there as doctors to actually support the government, both at the national government and the county government, to make this a reality. Remember, this is our bread and butter. So if the health sector is functioning well, then we'll be happy to actually operate within that system. But as it currently stands, I think we are not in a very good place. We need to actually go back to the drawing board and try get solutions that will outlive us. And just on the issue of the NHIF, I think I'd like to directly appeal to the president not to sign that bill into law because it goes against what I'm just saying, where you're trying to isolate the key providers from representation in the fund, and yet they're the ones who are supposed to be providing the service. So if you look like what was passed yesterday, KMA has been removed from the board of NHIF, and in its place they'll put KHPOA, which is a government agency. So the government cannot represent itself and say it's speaking on behalf of healthcare workers. KMA has actually participated in the reform agenda for NHIF. And when you are now to implement what you have reformed, you have been thrown out. So I think I'm directly appealing to the President that as doctors of this country, to look at that bill and turn it to Parliament so that the issue of accountability and NHIF being held accountable can actually be looked into.
All right. Dr. Ng'ani, closing remarks?
Yes, Trevor, the starting point for healthcare reform is to get leaders, and there's an acronym for that, a PIVA leader, P-I-V-A leader, a leader with a passion for changing healthcare. A person with integrity, because a big part of the problem you're facing is just the same across the country, lack of integrity and corruption. A person with a vision that sees the public health sector taking its place as, some of the best facilities in this country being public sector facilities. People tell me it's impossible. It's not impossible. It can be done. And then the ability to make that happen. That's a starting point. And I think getting PIVA leaders into those positions of responsibility will, even within existing resources, without even increasing the budget, we can really do a lot more within the resources that we have. Yeah. That's the first thing. The second thing is to look at healthcare workers not as enemies, because for the last 10 years, it seems to me that healthcare workers have been looked at, Kenyan healthcare workers, not Cuban healthcare workers, Kenyan healthcare workers have been looked at as enemies of the government. And I think the people who've driven this agenda, probably it's time to ask them to just take some time and go home a little bit so that we can have the true understanding that these are real stakeholders and that these are people who can bring something to the table, who perhaps let's try a different approach. Yeah. I would want every Kenyan to take an interest in healthcare. This is not a problem for the doctors. This is a problem for every single Kenyan. And make sure that healthcare is an agenda. Nobody comes to your house and asks for your vote if they don't tell you what they're going to do for your healthcare. Then as far as NHIF goes, and Trevor, for this, please allow me to speak in Kiswahili. I want us to understand that NHIF is our money. NHIF ni chama chetu. What we are saying is that it's very expensive for you to get healthcare as an individual. So what we are doing as citizens is we are contributing small amounts of money into this chama so that if when one of us falls sick, then this amount of money can be used to give you treatment. Yeah. Since it's our money, nobody can tell us that we cannot use it when we fall sick. And since it's our money, it also means that we must protect this money. Protect it from what? There's a lot of corruption targeting NHIF. And I really pray that as a country we become bold enough to start deregistering facilities, individuals, and people who are involved in fraud NHIF related, because this is our money. And the truth is NHIF will play a key role in social protection as far as healthcare services go. This is the first thing. The second thing is, even within us as a society, and we have to be honest with ourselves, there are those of us who don't pay into the chama, hawalipi pesa ya chama, lakini when they fall sick, they pay for that 2-month period, then they get 100,000 of service, then they go back again and stop paying. I think that is also not proper. So all these things we need to pay attention to, that we need to be able to take to change. But then also to the healthcare workers, something we haven't raised, Trevor, but it's a big crisis in the country today. There's a culture that we've imported from Asia, unfortunately. Unfortunately, I have to say it as it is, where we are beginning to exploit the mwananchi, where we are talking about filling beds and they're talking about utilization. We are having kickbacks into that space for referring a patient for admission or for other services that is not warranted. And that utilization is well grounded in some Asian countries, and that culture has been coming into Kenya. Unfortunately, it's been going unattended. And I'm asking us as a society to pay attention to that, because there has to be no room for that. I saw recently a family that was struggling financially, and there was almost a process of getting them into a facility where they're going to pay 100,000, and they've been hit by COVID. You know, the businessmen are looking at how to make more money from people who are struggling. I think that culture, we know where it has come from, and that culture has to be nipped in the bud, I think, at this time. And I'm making an appeal to every single healthcare worker out there. This must not be part of the Kenyan culture. It has to be stopped. So
people are being admitted to hospitals unnecessarily, or admitted to specific hospitals that are much more...
There is a culture that is cropping up where the decision around your care is not fully based on your condition. And this is very different. Sometimes people say that because the cost was so high, it was unnecessary. No, no, no. This is not what I'm saying. There are people who need to be admitted, and the test will be very, very expensive. But there are situations where it's not justified, and it is being driven right now by other objectives. And that objective is a culture that is introducing kickbacks for such processes, kickbacks for utilization, where you refer a patient for admission to a facility, you're going to get something back. I think that is a dangerous culture. It has been utilized already, but it has to be stopped. Okay. I think anybody who's out there who's who's listening, this is something you have to pay attention to.
Yeah, Dr. Davji, start by addressing that very issue as KMPDU. Are you able to take any action?
Yes, basically that comes with ethic. Yeah. We have to really put ethics in our service provision and ensure that our aim is actually to offer services to the Kenyans.
Yeah.
And we need to offer the highest quality within our abilities in every facility. But I was trying to say that in the country as we are, one of the major things that we need to do is to increase the budgeting to healthcare. Yeah. We've had discussions with People's Health Movement, with Amnesty, and I think last time we had a conference where we said for the next 200 days we want to put a fair nation, whereby we want Kenyans to put healthcare as an agenda for themselves in the coming political sphere of the country, so that if the budget is increased, most of the issues that we have will be solved. Yeah. Then the next thing that needs to actually be taken seriously is the employment of the doctors and healthcare workers that are outside here. Without that, we cannot get the services in any of the facilities that we need. We'll always just be having the doctors. It is unfortunate that we're a country that have shortages of doctors in the facilities, and then we have artificial excess of the same in the streets. So that's something we need to work upon as a country. Then regarding NHIF, I really feel that the mandatory contribution is a good thing for the NHIF because they're going to get a bigger funds. But what about for these unemployed in the country? How will the government ensure that every unemployed or every unsalaried person is able to contribute or is being paid for? That's something the government needs to work on strongly. Yeah. But then these funds that NHIF is receiving, which is in the tunes of 100 billion extra, because now even the employers will be contributing. How is the NHIF planning to account for this money when they're kicking out the service providers like KMA from the board? Yeah. How is NHIF planning to account for this money if they're kicking out the unions, like the NAT and KOTU from these organizations? It then means that the system is creating itself to repeat the scandals and the cartelizations of the funds, or the political players are going to use that particular funds in setting the political agendas. So that's something that we need to look at as a country. That is the funds that are going to have. Are they going to help us to get services? Then NHIF in itself, I saw recently the NHIF and Boda Boda signed an MOU. We saw NHIF with counties, different counties. But are there those facilities in the public sector that people are going to get these services? Yeah. Will NHIF, with these billions, be part of employing doctors in the hospitals? Will they be part of training the doctors? Will they be part of ensuring that every Kenyans are getting services, or they're just part of collecting the contribution? That's something that needs to really be looked at as a country. Right. Then basically, we've had discussions with the Council of Governors, the Chair of Health Committee, Professor Anyang' Nyong'o, and the Ministry of Health. We need to have a roundtable discussion, as Dr. Were had said, to ensure that some of these issues that are affecting healthcare, they do not persist to the point that we have to go on strikes, as that is always the only way that we have to bring some of these issues to the attention of the public and to the attention of the government for them to change.
All right. Yeah. Thanks for making time this morning, Dr. Davji Atela, Secretary General, KMPDU, Dr. Victor Ng'ani, Critical Care Doctor, and Dr. Andrew Were, President, KMA, for that conversation. And thank you most for sending in your views and comments. We'll still keep an eye as Citizen TV on the state of healthcare and ensure that something happens, all right? That note, we're taking a quick break here on Daybreak. When we come back, it's time for Working Out with Willis Bazu Raburu. See you in a bit.
So what do you expect me to do? Nikwende?
Itabidi ujishughulikie.